Hello, I'm Dr. Manvi Smith, a psychologist in primary care, and today I will be talking about safety planning as an evidence-based intervention for suicide prevention. Next slide. The goal in developing a suicide risk assessment and safety planning protocol is to provide patient care that utilizes evidence-based interventions and tools that meets best practice guidelines as well as Joint Commission standards. It is important to understand the steps in caring for our patients, even in different care settings, remain consistent. It starts with identifying risk. Once risk is identified, risk assessment is undertaken with the Columbia Suicide Severity Rating Scale. The intervention is safety planning. Next slide. Before we talk about safety planning, we will address why we recommend safety planning instead of no-harm contracts. No-harm contracts involve a commitment to what a patient will not do in crisis. It is not recommended for patient care because there is no evidence that they work. It is not a legally enforceable contract, and what it does do is show that a provider believed that the patient posed some level of risk to themselves and simply took their word that they would be fine. No-harm contracts are clinically ineffective as an intervention and are a risk and liability issue. Safety planning, on the other hand, is an evidence-based intervention that saves lives by focusing on committing to what a patient will do in crisis or to manage a crisis safely. Next slide. Suicide is a public health crisis. The use of safety planning, an evidence-based intervention, is recommended by the Joint Commission as a standard of care for those who have been identified as being at risk for suicide. Safety planning is an intervention in which a safety plan is developed collaboratively between the patient and the clinician. It involves identifying warning signs or triggers for a suicidal crisis, constructing a list of healthy activities or strategies to help the patient manage the suicidal crisis, listing their reasons for living and supportive social contacts, providing crisis resources, and taking steps to ensure that their environment is safe. You can address safety planning with a patient by saying, "A safety plan is a good thing to create and have if we have depression and suicidal thoughts, because when we are in crisis, we may not be able to come up with the resources or tools to help with the crisis. This is your guide for helping you through a crisis." It has been my experience that this approach is more likely to lead to patient engagement in safety planning. Next slide. Step 1, means safety. In this step, we are assessing for lethal means and engaging in safety planning all at once. Lethal means are methods for suicide that have a higher potential for harm when compared to other methods. Pills and firearms are examples of lethal means. The goal of means safety is to increase the time and distance between the patient and their access to lethal means during a suicidal crisis. When asking about firearms, I start by assuming that everyone is a responsible gun owner, and I ask, as a responsible gun owner, how is your firearm stored? This is a multi-select, and please select all options that apply when engaging in safety planning with the patient. Next slide. Step 2, identifying triggers or warning signs. This can help the patient better cope because they are aware of these triggers. They can take action to manage them. Warning signs can range from emotions, thoughts, to arguments or events. In talking with the patient about their warning signs or triggers, ask them what would let them know that they need to use their safety plan, or what should they look out for. This is also multi-select. Please select all options that apply. Triggers specific to the patient can be listed under additional considerations. Next slide. Step 3, Healthy actions. Patient-led healthy actions to help the patient manage their crisis. This includes positive, enjoyable activities, reaching out to others, relaxing or soothing activities. Ask the patient, what are some things that help you? We want to make a list so that if you are in crisis, you have a list that helps you manage the crisis. This is also multi-select. Patient-specific healthy actions can be listed under additional considerations. Next slide. Step 4, reasons for living. When patients are in a suicidal crisis, they may not immediately connect with what is important in their life. Listing this on their safety plan helps patients connect to what is truly important to them, whether that is their family, pets, personal growth, or their religious beliefs. Ask the patient, what is most important to you? Similar to the other sections, this is also multi-select, with additional considerations for patient-specific information. Next slide. Social supports. It can be helpful for the patient to have a list of individuals or an individual that they can talk with when they are experiencing a suicidal crisis. This may be someone whom they can trust, or someone who can distract them, or someone who makes them feel better. Ask the patient, who can you reach out to? Next slide. Step 6, crisis resources. Patients are given crisis resources that they can call. This includes the National Suicide Prevention Lifeline, the Crisis Text Line, or an app that they can use, the Virtual Hope Box. The Virtual Hope Box is designed by the Department of Defense's Telehealth and Technology Center to support veterans. This app is free for anyone to use. It supports a mix of preloaded and user-created content. The preloaded content includes music, relaxation exercises, games, and even a link to the National Suicide Prevention Lifeline. User-created parts of this app are photos of friends and family that the patient can add, sound bites, videos, reminders of their special moments, and reasons for living. Always let the patient know that in an emergency, they can call 911 or go to the emergency department. Next slide. Next steps, plan of care. The Joint Commission recommends having a plan of care in place when working with patients who are at risk for suicide. Behavioral health treatment. We assess if the patient is currently receiving behavioral health treatment. If they are, it allows the clinical care team to obtain consent to reach out to the behavioral health provider and let them know that the patient is at risk for suicide and a safety plan has been developed. If the patient is not engaged in behavioral health treatment, a referral can be placed. The clinical care team can also document if the patient declines the behavioral health referral. Including others. The patient can identify a family member, significant other, or friend to include in the safety plan. This individual may already have been identified to help manage medications or for ensuring firearm safety or as a social support. The clinician can encourage the patient to call this individual from their phone on speaker setting during the appointment and include them in the safety plan. Medication management. This step allows the clinician to document medication management, initiating medications, adjusting medications, continuing medication. It also offers the option of limiting the quantities of medication available to the patient. Clinical care team follow-up. A follow-up phone contact for patients who have engaged in safety planning has been found to decrease the risk for suicide attempt. Depending on the assessed risk level of the patient, clinical resources available, and clinical judgment, the plan of care can include a follow-up call. Emergency department. Depending on the assessed level of risk, a clinician may recommend that the patient present to the emergency department. It allows the clinician to document whether the patient is agreeable to this recommendation or if they decline. It also allows the patient to consider, when appropriate, the option of involving local services to evaluate the patient. Next slide. The patient should receive a copy of their safety plan. It can be printed along with the AVS by going to the safety plan tasks and selecting yes to activate auto printing with the AVS. Encourage the patient to take a picture of the safety plan or even write it in the notes section of their phone as you are working on it collaboratively. Recommend that they keep it somewhere where they can easily access it when they need it. Next slide. This is how the crisis safety plan appears in the AVS. Next slide. In conclusion, safety planning is an evidence-based intervention for individuals at risk for suicide. We hope that this presentation has been helpful. Thank you.